Oh, I see that somebody has joined my APQA meeting. I don't know if they have the wrong link. Aditya Menirajan. Anyway,
Oh yeah, let me send that off to them too. Yeah,
okay,
I put in the wrong Zoom link to them, so I will email them, let them know.
okay.
Those are the rotating students.
Okay, thanks. All right, so I did not add any new slides because I think we have enough to discuss. Let me rephrase that. I didn't add any new unknown slides because I think we have enough to discuss today. I did add some sort of bonuses that I have not expected you to preview, that we can just sort of talk about together. So one of the things that came up last time was, the difference between non-ossifying fibroma and aneurysmal bone cyst solid type, and some of the, other spindle cell lesions of bone. So I just wanted to give you an example of non-ossifying fibroma. And in fact, this I found on Path Presenter. So really cool that they have this radiology, but you could see this kind of characteristically described as soap bubble appearance to the lesion in the shaft of this long bone. It's sort of at the junction between the diaphysis and the metaphysis. And this is a good radiograph to remember, I think, especially for board's purposes, that NOF is a very, very common reason of pathologic fracture in kids for this underlying lesion that is benign, yet still weakens the bone and causes fracture. So you can actually see this very nice kind of sharded bone at the edge here that's kind of fraying out and kind of locating the bottom part. And so what the NOF looks like on histology is here. And so NOF is not a joke. It actually should really not be ossifying. So if you see a lesion that is purely spindle cells with giant cells and little to no bone, that would be a good sort of initial indicator of possibly a non-ossifying fibroma. The reason that this is slightly different from a solid aneurysmal bone cyst is, sorry, it's a little bit thickly cut. This was not my slide, but it's a little bit more densely cellular in the background, and arguably the spindle cells take on a somewhat more, I think this is a nice area, somewhat more tightly packed storoform appearance, such as what you'd see in really like a dermatofibroma or a fibrous histiocytoma of the skin. That being said, there are nicely scattered giant cells, and the giant cells are sort of being compressed or like squeezed, I think, by this storoform stroma. And what else? Sometimes they can undergo, I guess that's not really necrosis, that's just fibrosis. Sometimes they can undergo necrosis secondary to pathologic fracture, but that is okay. That is a known acceptable finding in NOF. So, arguably those cells in the background aren't as haphazardly arranged. They're a little more cellular, a little more storoform, really not much in the way of cystic spaces and lemmings, so to speak. So hopefully that clears up NOF. I will immediately after the talk, I will send out this full presentation so that you will have all of the diagnoses with the PowerPoint slides, and you can sort of review them all in concert, and hopefully that will assist. Questions? Cool. Yeah, this was our solid ABC. So, arguably a little more variability in the density of the stroma. The cells are a little more wispy, less tightly packed, but, subtle differences. Okay. I think we got through the giant cell tumor, right? Did we get through? Yes, we got through the EG, right? Sorry, go ahead.
Oh, yeah, I was going to say we did get through that one.
This is where we resume, yeah?
Mm-hmm.
Okay, go for it.
All right, so on the left, you see like an X-ray of this one also has sort of a soap bubble-like appearance. Like you classically get these lytic lesions that are almost always in the tibia, And they usually have kind of a sclerotic rim around like the outside of the lytic lesion that gives it that sort of characteristic classic soap bubble appearance. And on MRI, they tend to, I think I actually put these in here backwards when I put the images in here originally, but they're typically like hypodense on T1, bright on T2 because of like some of the sort of cystic spaces that you can see in them. And they brightly enhance with contrast, which is on the far right. So uh, that's what we tend to see with this, what we're about to see next. It's pretty classic.
Cool. So this location and this age, so tibia, male, young, usually centered in the sort of anterior tibial cortex, but arguably variably located. So this clinical picture and this histologic picture, burn it into your brain if you haven't already. So who wants to describe what they see? I'm going to
I
start.
could try.
Oh,
I
yeah,
could
go
try.
for it. Mhm.
So I'm seeing proliferation of spindle blend spindle cells. Like they form kind of story form.
Mhm.
They are bland. I didn't see any mitoses. Some blood vessels.
Mhm.
So it reminds me about the appearance of fibromatosis in the soft tissue tumor. That is the impression that I got when I see it.
Okay.
So I believe those are myofibroblasts.
Mhm.
So I would do some ISC to confirm.
Okay.
So I'm thinking about something fibroma, desmoplastic fibroma,
Mhm.
maybe. Yeah, that's what I'm thinking, but I need ISC to confirm the nature of these spindle cells.
Okay. Anybody else want to add any other findings? And then we'll discuss IHC. Somebody tell me that they saw these islands here. Thank you, Jasmine. What do you think those stellate islands are?
Osteoblast, or I don't know, or related to blood vessels. Epithelium.
Jasmine says epithelium.
I was almost thinking like an adamantinoma kind of
Yeah.
look.
So tell us about adamantinoma, either Jasmine or Perry.
I know it has those like classic little epithelioid islands. This doesn't, I guess these didn't look quite like the image that I'd seen in like a textbook. I thought they were more like islandy in the book, whereas here they almost look arborizing or like this kind of network. But so I don't know if that's allowed or that's like a totally acceptable variant. So yeah, that kind of reminded me, that was my first thought when I saw this. Although this area doesn't really have them.
Right. Yeah. So descriptively, this is a very heterogeneous thing, right? So some of these islands, like we first landed on, are completely sort of fibroblastic, myofibroblastic, with this very packeted storiform architecture that, yeah, maybe resembles a fibroblastic or a myofibroblastic type of lesion. I can't really argue with that in this field. But when you really evaluate the tissue thoroughly, you'll see that these compressed islands pop up here and there. And, you know, on occasion, you may think, are these compressed blood vessels? And on occasion, maybe they are, but some of them don't really have lumina. Some of them, at least in that area over here, which I think is probably the best, they are multi-layered, right? So you really wouldn't expect an endothelial vessel to have 1, 2, 3, 4, 5, 6, 6 cells across as a cord. So that's suspicious. And again, this clinical situation is extremely characteristic for this lesion. So if you think they're epithelial, what do you want to see?
Cytokeratin, maybe we should do cytokeratin.
Cytokeratin, yeah.
yeah.
So here's a keratin highlighting these compressed epithelioid islands. And it now becomes quite obvious how many of them there are.
Yes.
And that's why this, even in the areas that were predominantly fibroblastic, you can see that there are hiding little nests of cells that we did not see on H&E, right? That are highlighting with the keratin. And so I would urge you in all cases of this differential diagnosis to throw on a keratin. So there are basically 3 things we're looking at potentially in the anterior tibial cortex of a young male. What are 2 of them are variants of the same, and 1 is slightly different. So as you guys correctly noted, this is an adamantinoma. So the adamantinomas can have 2 different histologic subtypes, where one is just these compressed, almost endothelial or vascular appearing cords. This is the so-called well-differentiated adamantinoma, which is what we are seeing. The classic adamantinoma that looks more like a ameloblastoma of the jaws, or even like sometimes a craniopharyngioma perhaps, is more obvious, right? Seen on the right here. It's these giant islands with even some keratinizing cells. So both of these histologic variants are good for adamantinomas. Both occur on the anterior tibial cortex of young males with these epithelial islands in the background of fibrous stroma. These are generally sort of considered potentially aggressive in terms of they can metastasize in rare cases to sites like a lung, but they're not overtly necessarily considered a sarcoma. On your differential would be the diagnostic entity that does not contain epithelial islands. And that is what I'm showing you here on the next slide. I didn't put this in the original, I don't think, but I have this here as comparison. So the difference here is that it is entirely this sort of storiform, loose fibroblastic, myofibroblastic stroma with bone forming islands. So here's osteoid with nice osteoblast rimming. The osteoblasts look generally quite monotonous and bland. And then as you progress, they sort of mature out to a little bit more woven bone with osteoblast rimming again. So a pattern, an architectural pattern of fibrous tissue as well as bone. So this would be one of the fibroosseous lesions of bone. So does anybody know the name for this one? That's the anatomic correlate to adamantinoma, but without the epithelial islands.
Ossifying fibroma,
Ossifying fibroma.
osteofibrous dysplasia.
Yeah, osteofibrous dysplasia is the more accepted term in the long bones, exactly. And so, ossifying fibroma is the more accepted term in the jaws. Osteofibrous dysplasia is the more accepted term in the long bones. But whenever you have an osteofibrous dysplasia-like lesion, arguably you should probably throw a keratin on there to see if it has any epithelial islands that might throw it into the pattern of a well-differentiated adamantinoma. Clinically, there's potentially some difference in terms of the aggressiveness once it has epithelial islands, potentially more aggressive, but this can be challenging, especially if you only have a small biopsy. I remember specifically, unfortunately, I don't have the slide anymore. In this case of the adamantinoma, this was the second biopsy, and the first biopsy only had epithelial pore areas, like it only had fibrous tissue. And so, I don't believe a keratin was performed on that small biopsy, but if it were, it may have highlighted some of these very, very small. There they are. Now that we know they're there, right now we can see them, these epithelial islands. So if you have what you think is an osteofibrous dysplasia, maybe just throw a keratin on it, because it's a very much of a histologic spectrum between OFD and adamantinoma. So hopefully that was helpful. These are not common tumors, these are rare, but knowing that they exist and knowing how to work them up, I think is useful. Questions, comments? Okay,
All right.
cool. What?
Oh, I was saying, okay, cool.
Okay, cool. So now we move on to a lesion in the coccyx of a 53-year-old male.
Okie dokie. So I pulled up the MRIs for all three of these guys. So it's right here at the end of the tailbone. It's kind of like this little 5 centimeter like dingus hanging off the end of the tailbone here. It's at the midline. It's pretty hyper intense on T2 classically. It's very hypo intense on T1. So it's not very fat rich. It's very kind of more cystic or like fluid density. And it enhances, and it does enhance with contrast, although this isn't the best image. You can see that it does show some enhancement on the very far right.
Here.
Yep, there he is. There's the dingle dangle.
There's the dingle, and we have a nice sound effect for it too. So, just remember, this is bladder, right? So this giant white thing is urine, right? And
Yep.
then lesion is here. So we have a lesion at the tippy tip of the coccyx. So even before I show you the slide, like what should your little brain, not little brain, what should your big, deep gyri and sulci already be thinking?
I mean, you should already be thinking about like a chordoma, like midline, old dude, probably a chordoma.
All right. So what are the two sites where chordomas exist, or let me rephrase that. Where are the two sites that chordomas primarily arise in the body, other than the sacrococcygeal
Clivus,
area?
like the clivus upstairs.
Yes, the upstairs. So the upstairs and the downstairs. So at the ends of sort of opening and closing of the primitive notochord, right? So the basically base of skull and sacrococcyx.
Spider.
What?
Oh.
Spiders? Only in those two areas should a chordoma primarily arise. So we're going to see if indeed it is that. But we've already kind of given away the answer by the location and by this discussion. But who wants to at least describe these cells and tell me if they think they're appropriate for a chordoma and what immunostains you might want to order in this context? Somebody who hasn't spoken yet, please. I'm going to start calling on you. How about Brooke?
Hello. I can't remember from when I previewed this last week. My thought for immunostains was that it would be something like GFAP, but I discovered that was incorrect, and I can no longer remember what the correct answer was.
Okay. And morphologically, let's step back. Do you think this is appropriate for a possible chordoma, and what would you be expecting to see?
I don't remember the morphologic features that we're supposed to see in a chordoma.
Okay. How about FISA?
Yeah. So yeah, I can tell. So it looks like there is do you mind if I was looking at my own computer.
Yeah, look
but
at your
there's
home.
these like very bubbly kind of cytoplasm that could be like glycogen. And then we have mostly like on low power, it's more like lobular architecture with like some fibrous bands around it.
Mhm.
And then we have some myxoid metrics,
Mhm.
and the cells with like very clear cytoplasm. With all these things, I think, and then with the site and the age, I felt like that's a chordoma. And regarding the stains,
Mhm.
I would like to have a site like keratin,
Mhm.
EMA,
Mhm.
S100,
Mhm.
and I think that would be my stains that I'm expecting to be positive for that.
All right. So yeah, I'll comment on that, on the stains in a second. So morphologically, yes, we have these single cells, we have these nests, we have these cords, we even have these almost pseudo glandular spaces
Yeah.
of these very plump eosinophilic cells with sort of oval nuclei, small nucleoli, and these intra sort of cytoplasmic vacuoles or bubbles. And so what's the name for these cells when you read them in the textbook, which is meaningless unless you know Greek?
Oh.
Tim got it.
What? Oh, you
But yeah,
got
of
it.
course,
Physalliferous.
Physalliferous.
Yes. Oh, sorry, I just annotated inappropriately. So, so physalliferous is essentially like bladder forming. So these cells basically have nice Physa. These cells basically have bladders in them, or bubbles. So yeah. The other thing that's interesting about chordomas is that, yes, they stain for the three markers that you already suggested, which is EMA, which is keratin, and which is S100. And so we don't, unfortunately, have brachyury in our institution because we don't see enough of these to make it worthwhile. But that is the one absolutely 100% specific immunomarker. So brachyury is of notochordal is a marker of notochordal differentiation. And so you should really only see brachyury in chordomas. And so I think this is not brachyury. I think this was, this might have been EMA. Yeah, I think this was EMA because it's staining only the cytoplasm and not the nucleus. S100 should stain both. This was an outside case, so I'm sorry the immunos aren't perfect, but yeah, this here it is. This should be, if you give me, this should be your brachyury because it's a nuclear stain. So let me just go over to the positive control here. Yeah. So this is your positive control chordoma. So this is your brachyury in the nucleus, but also somewhat staining the cytoplasm. This, if I'm not mistaken, should be your EMA. Yeah, right. So this is staining epithelial islands. So this is your EMA. Exactly. So interestingly enough, there are a few things that might enter into your differential if you see something like this not in those two perfect sites, right? So you might see intracytoplasmic vacuoles with strands of cells in a myxoid stroma. Like that might make you think of something vascular, like an epithelioid, hemangioendothelioma. You might see these strands of cells in a myxoid background that's stained with keratin that might make you think of a myoepithelial tumor. And so interestingly, the keratin, EMA, and S100 could all be expressed in a myoepithelial tumor of soft tissue. Brachyury should not be. And so if you ever historically, I only mention this because historically in the literature, there were these things called parachordomas. I don't know if you've ever read about these. Parachordomas were thought to be chordomas arising off midline and in the peripheral soft tissues. These are not. These are basically myoepitheliomas because they really shouldn't and don't have brachyury. If they have brachyury, they're probably metastases of chordomas. So even though chordomas don't have a malignant terminology to their name, they can be very locally aggressive. They can recur. They can metastasize in this histologic form of epithelioid cells. What they can, parachordomas right there. What they could also do is dedifferentiate into this high-grade spindle cell neoplasm. These high-grade spindle cell neoplasms should retain brachyury, and you should see something that is more well differentiated nearby, like almost like a D. diff chondrosarc, kind of the same pattern of like well diff, D. diff in areas that are right next to each other. Comments, questions, challenges? Oops, whoa. Any of you who, I think some of you were here a couple years ago when Peter Nielsen came and spoke about chordomas. If anybody sees chordomas, you know, Mass General is the sort of chordoma center of the US. And so a lot of these get resected there. This gross image is a nice kind of tip of the sacrum with expansion into this lesion here, which looks kind of, I don't know, almost fatty or glassy or mixoid or gelatinous on gross. So those are chordomas. So we see them in the tip of the coccyx, and Peter also sees them up in the base of skull. So I'm sure you'll probably learn about them in neuro as well. Questions, comments? I think Mayo, when we don't have any immunostains here, we generally send them out to Mayo for tech only. So they perform the stain, they send it back to us and reinterpret it. So if there's ever any stains we don't have that we need, that's a pretty good way, including brachyury. Okay, 72 male, left ilium.
All right. All right, so I pulled up the CT for this one because it's kind of the only thing you really need to look at to be sort of a good radiologic correlate to what we're about to see. What you see is like this kind of patchy sclerotic kind of stuff arising in the bone, like all over the ilium. And both the location and the sclerotic appearance are kind of like the key characteristics here. They're the correlate for what we're about to look at.
So when you are dealing with a bony lesion in an old person, you know, there's basically 5 things that are on your differential. And they're all, what are your top 5 things? Mets.
Yeah.
Mets, and Mets. Okay, great. And then the second thing, which I'll show you in a minute. So, okay. So who wants to describe what they see here?
I mean, I was kind of saving myself for this one.
Well, take it again. No one else seems to, everyone else is sleeping, so you go for it.
So, as Heather said, old age guy, sclerotic lesion, your step 1 first aid book should just like guide you to pick the answer right away. But then if you scream, scan the slides, you will see like some islands of cells that if you really, we can go down here. It's a good area. And then these cells looks like epithelial. And if you go higher power, they do look pleomorphic. And then at this point, I will just like stop and like try to look up for the history of the patient and and specifically for like a prostate cancer history. So I would do a PSA, and I think this is a Mets from prostate cancer.
Mm-hmm. Is there anything about the morphology that might send you in that direction?
Big goobery nucleoli, probably.
Yeah. So in an old guy with sclerotic lesions, you know, prostate, first metastasis, second prostate. Yes, lung is always a good consideration. And so there's a few points I just wanted to mention with these osseous lesions in adults that are clinically suspected to be metastases. Usually they're clinically suspicious. Sometimes all you get is crush, right? So if all you get is crush and you're like, I don't know, please just do a keratin. Just always do some kind of AE1, AE3 or some kind of keratin, because oftentimes these crushed cells will highlight, even if the cytomorphologic features aren't quite perfect on the H&E, they often highlight a lot on the immunos. In this case, there's obviously something here that is not normal marrow, right? It's these very large pleomorphic appearing cells with prominent nucleoli that are crushed between fibrous stroma. And so this also happens a lot with in the female counterpart, right? In breast. Sometimes breast cancer is just few scattered cells, just kind of compressed between this fibrous background. So if you don't see marrow fat, if you don't see hematopoietic marrow elements, if you see this nondescript fibrous stroma with crushy cells, chances are you may have actually gotten the lesion. In this case, the lesion is apparent. And so yes, these nests of cells with quite prominent nucleoli should certainly make you think about prostate cancer. Always check a PSA. Check to see if the patient's had a serum PSA done, because that might really, really help you. If the PSA is low, it could still be prostate cancer, but sometimes these poorly differentiated prostate cancers lose expression of PSA. And so you may not actually see PSA or PSAP staining on your tissue. Usually if the PSA is high, you'll see PSA staining on the tissue. If the PSA is low, you may not, even if it in fact is prostate. So those were a couple points I wanted to make. Keratin in this case strongly highlights what we see in this, what we saw in H&E with these nests. And then let's look at the positive control. Okay, that's PSA. And then, whoop, yep. So in this case, we got extremely lucky. So this guy has nice diffuse PSA plus keratin staining in his metastatic prostate carcinoma. So thank you all for that. Does anybody have thoughts, questions? I thought this was a nice, very, very classic example. Before I go there, I'm going to try to show you the next thing that you might see in adults. You haven't seen this one. This was a frozen that some of you might have seen this, because this was the frozen that one of the frozens we had on our Leica validation. Sometimes the cutting is imperfect, right? So we have some chatter artifact with these shards and strands of cells. But, let's look between the shards and strands of cells. So the only thing I'll tell you on this is also an adult patient with an osseous lesion. Reham says plasma cells. Yeah. So round nuclei with, the chromatin, put whatever name you want to this chromatin, clock face, whatever, but basically areas of dark and areas of light. And we have a moderately abundant cytoplasm at the edge. Occasionally it may appear eccentric. It's not perfect. Oh yeah, there's maybe a few with eccentrically located cytoplasm and the nucleus shoved off to the side. And so this super round cytologic monotony with occasionally eccentric nuclei in an adult patient, you certainly want to think of a plasma cell neoplasm. So, get used to looking at these on frozen, because you're going to get them. So you're going to get plasma cell neoplasms on frozen for adults. You may get metastatic carcinomas, but more often you'll probably get a plasma cell neoplasm, because if you can diagnose that on frozen, they'll probably just curette it and move on. And so we tend to not necessarily at the time of frozen diagnose these as multiple myeloma, because sometimes it's not certain whether this is a solitary lesion or diffuse osseous lesion. If it's a solitary lesion, what might the terminology be for it?
Like a solitary plasmacytoma?
Right, like a solitary plasmacytoma. More often than not, however, these patients do have diffuse osseous lesions with serum proteins. In that case, it would be multiple myeloma, but always clinical and radiographic correlation is needed. Exactly. So plasma cell neoplasm is a good way to sort of cover all bases, whether it's a solitary plasmacytoma or a true multiple myeloma. So yeah, so this is that. I'm sure you'll learn more about that. You have already or will learn more about this in heme than you ever will with me. However, you will see these on the bone service from your orthopedic surgeons. Questions, comments? What you don't really see, which is maybe in contrast to that eosinophilic granuloma that we saw earlier, right? You don't really see cleaved or folded or grooved nuclei, and you don't really see background other inflammatory cells, right? I don't see neutrophils, I don't see lymphocytes. Okay, Cool. If anybody is brave enough, I have one, all right, 8:40. So I have one last set of cases that I haven't shown yet. This is completely new. So I'll just drive around, and if anybody has thoughts or comments, this is a young person. This is a young person with a lesion of the long bones, but we hadn't covered this yet, so I wanted to throw it in. So I'll drive around, you think about what you're looking at, and you tell me what you think it might be. Or if somebody wants to take the screen control and drive, I'd be happy to do that as well. Ben says in heme, we would typically don't sign out multiple myeloma, as this is the clinical diagnosis, as instead top line plasma cell neoplasm. Oh, excellent, great. So I'm not off base. Oh yeah, Ben, while we drive around, did you also want to comment on what you found out about BRAF from last time, about the EG and the LCH and the mast cells?
Sure. I don't know where I read that. Yeah, if you guys remember, we were talking about the BRAF IHC and whether it's positive or how sensitive it is in Langerhans cell histiocytosis. And for some reason, I was thinking that it wasn't very sensitive. I'm not quite sure where I read that. It might have been from an old board's review book or something. But I mean, the data is a little inconsistent, but it does have pretty good sensitivity and specificity. And then actually, I was wondering, oh, maybe it was hairy cell leukemia that I was thinking of, which also has the BRAF V600E mutation, but that is actually even more sensitive and specific. So as Dr. Cipriani said in the previous lecture, the BRAF IHC is a good one. It performs well.
Thanks. Yeah, I think so far in pretty much most systems that I've read about, I think it's pretty good.
Yeah.
Yeah.
There's always issues because I think it can be a little weak.
Yes.
And so
Yes.
you really have to have a good cutoff of what to call positive versus negative.
Yes. Yes. Like we've seen in some of our thyroid cases, it can be extremely weak, but if it's diffusely weak in all of the lesional cells, that really is predictive. Yeah.
Yep.
Yeah. Cool. All right. So you've had a chance now to look around at what I've been showing you. Does anybody have any thoughts in this young patient? With a lesion of the long bones. I don't even need to show you the radiology because the histology is so characteristic. Reham says cartilage forming tumor. Yeah, so there is definitely a chondroid matrix. I completely agree with this sort of bluish stromal material with these curvilinear blood vessels with some cells in the background that are kind of stellate to spindled, arguably. You may notice that it has a sort of, it kind of came out in these lobules, and at the edges of some of these lobules, you do see some peripheral hypercellularity. You do see some more eosinophilic stromal material as well. Does anybody want to offer a differential diagnosis?
Do we have any osteoid, like the tumor cells form osteoid, or it just like this? Maybe here?
So eosinophilic stromal material can be challenging. It could either represent, collagen or osteoid. Arguably osteoid is fine and lacy. This is a little chunky and globby for osteoid. So my vote would be no on this area. And Perry says chondromyxoid fibroma, question mark. So tell us what you know about chondromyxoid fibroma.
Not much. I think the the edges, the periphery can be a bit busier. I think it has that like compressed, spindly cell look.
Mhm.
The background, I think, is sort of chondromyxoid, which I
Mhm.
suppose would fit with this as
Mhm.
well. I think, yeah, the busyness at the edge was
Yeah.
maybe a good hint.
Yeah.
Is it lobular? Maybe
Yeah, I mean, I think when it is biopsied in chunks like this, the
it's hard
lobular
to
architecture
really,
is hard
yeah,
to appreciate,
can't really
but
tell.
the peripheral cellularity, and when I mean peripheral, it's sort of, you know, yes,
We have
here
to,
it's
yeah, we have
literally
to
at the periphery
imagine.
of the tissue, right? Exactly. But here it's at the, oops, it's hard to drive. Here it's at the periphery of each of these lobules, but in this, you know, kind of as a crescentic shape between. Yep, exactly.
Like we have to imagine what it would have been
Yes,
inside too. Yeah.
imagine. Imagination is always very helpful in pathology. Awesome. And so is this benign, malignant? Are we worried? Are we not worried?
Benign, right?
Yeah, so most chondromyxoid fibromas, if in fact that's what they are benign. And so I'll show you the slide before I show you the rest. So here's the classic appearance of this sort of lobulated architecture with peripheral hypercellularity. And occasionally, in the case that we saw, I don't really see many of these or any of these, but sometimes you do see giant cells, osteoclast-like giant cells in these areas of hypercellularity at the periphery. So sometimes this is grouped in with the giant cell rich lesions. Sometimes it's grouped in with the chondroid lesions. But this is essentially another one of these long bone of kids, usually in the marrow. And here's a nice radiographic appearance of it. And so I wanted to share one of these cases with you because of the challenges that I had with it. Let me see if what am I showing you here? This just, oh, this is something else. This is something else. This is something else. I think this is out of order. Yeah, okay. So sorry, I'm gonna skip down here to this lesion. So keep in mind what chondromyxoid fibroma looks like. I'm skipping down to this lesion here, which we saw on Frozen not too long ago.
This is scary.
This is
Scary comparable to, oh yeah, this is malignant.
yeah, this was scary on Frozen. I
Yeah.
agree.
Increased cellularity, kind of hyperchromasia.
Mm-hmm.
So here we have cartilage, like it could be chondrosarcoma or osteosarcoma forming.
Mm-hmm. Yeah, like a chondroblastic osteosarc or a CMF-like. Mm-hmm.
Yes.
Yeah. So remember on Frozen, right, with bone lesions, that caution is always your friend. And if you see things that are pleomorphic or hyperchromatic or scary to you, just please say, there is a chance that this could be malignant. Please stop. And so hopefully they will send you more tissue. You'll get some better tissue to evaluate, do the appropriate, testing on, and come up with a diagnosis. But on Frozen, this similar kind of chondromyxoid backgroundy lesion with these pleomorphic cells was very worrisome. And so here's a section of additional tissue that they sent for permanent only. So I'll just show you that. Is that yeah, that's a giant cell. Does anybody have any additional thoughts based on the permanence. And as I said, I'll send you this presentation afterwards so you can look at it on your own as well. All right, type in the chat if you think benign or malignant. I don't even care what type of diagnosis. Just tell me if you think benign or malignant.
Do we see any mitoses? I'm not able to see any mitosis to confirm malignancy.
I thought we passed one. Did we pass one a ways back? Looked like they were pulling apart.
Yeah, but this is scary.
We may have. Let me keep looking. Nobody wants to commit, I see. I don't blame you. I don't blame you. Maybe a mitosis, maybe not. I agree with you. They're not obvious, right? They're not obvious, but these nuclei are kind of strangely pleomorphic.
It's something low grade. If it's sarcoma, like chondrosarcoma, it would be low grade.
All right, so to not prolong the agony, I think this was a great lesson learning case for us. So this is the final ultimate diagnosis on this case after many send outs to many consultants and a lot of agony, is a pseudo malignant or a so-called pseudo anaplastic chondromyxoid fibroma. And so there are reports of so-called pseudomalignant change in benign lesions. This is one of them in which that can happen and can be very scary. But behaviorally, these are not aggressive. And so one point that was made that is, I think, very good is the absence of really overt mitoses. And so yes, you can see a mitosis here and there in these lesions, but they shouldn't be multiple. They shouldn't be atypical. And if you can confirm that clinically and radiographically, this is consistent with a benign appearing lesion of bone, and you see these hyperchromatic, pleomorphic, smudgy looking cells without tons of mitoses, consider that this could be quote unquote pseudo-malignant or pseudo-anaplastic change. And so, arguably, the hyperchromasia is a little bit smudgy. Certainly there are a few mitoses or no mitoses, but this was a very challenging case. And so always keep in mind some kind of pseudo-malignant change. So we were cautious on the frozen, and after multiple, iterations, this turns out to, in fact, we think be a benign lesion. So that's that. I certainly learned from this case. Yeah, you're welcome. I think 8:52. We may have, if I'm not mistaken, does anybody have questions or comments? I'm just going to drive around this last one in the last minute or so. Oh, yeah. I know what this is. Sorry, I forgot for a second. So this was frozen 1. This was permanent 1. This was a second procedure on that same patient in which they curetted out some additional material. Same exact patient, same exact case. Now even more hypercellular with residual pleomorphic nuclei. But again, really mitotically poor. It's hard. I think that's not a mitosis. Okay. So yeah, this is that exact same patient showing slightly more overtly chondroid areas, still with bizarre pleomorphism, also with hyperchromasia, also sent out to consulting pathologists who still call this pseudomalignant. So there you go. That's all I wanted to say about this case. I don't usually do Ki-67s, but I think, yeah, this, let me just make sure. Yeah, so we did a Ki-67 in this case, just out of curiosity, especially in that hypercellular area. You know, and it's not nothing. So I'm curious in this patient to see behaviorally how this lesion progresses or does not, because I was a little worried about it. It has a relatively increased Ki index, whatever that means in this hypercellular area. So to be determined, but I thought this was, I'm going to reorganize the order of this so it's in proper order. But because this was a nice recent active case, I thought it might be nice to share. So questions, comments, criticisms, concerns? Okay. That's it for now. If you guys have any other lesions that we didn't cover that you want to see, I know my teaching is done for June, but you know, always happy to show more if you guys need. As I said, I'll send out the link to this final presentation.